At the end of this lecture, you must be able to understand basically what is hypertension and what are the different types and what are the factors responsible for the adjustment of blood pressure and what are the drug strategies to control the blood pressure and what are the different uh, drugs group that can be used to control the blood pressure, then individually role of diuretics in the treatment of blood pressure and the drugs influencing the sympathetic nerves towards controlling the blood pressure. So first of all, we must know that arterial blood pressure is determined by the cardiac output and peripheral vascular resistance. This is important. That means if cardiac output increases, it will increases the blood pressure. Or if there is increase in the peripheral vascular resistance, that will also increase the blood pressure. And how cardiac output is going to increase? There are different reasons, but mainly cardiac output increases due to activation of which autonomic nervous system? Sympathetic, parasympathetic. Sympathetic, right? Sympathetic nervous system activation is responsible to increase the cardiac activity, especially due to stimulation of beta 1 receptors. That will increases the cardiac contractility and increases the heart rate. And due to stimulation of alpha 1 receptor, it will lead to vasoconstriction. It will increases the peripheral vascular resistance, and that will ultimately increases the blood pressure. Because when there is increased peripheral vascular resistance, what it will do, it will increases the venous return, and this increased venous return ultimately increases the cardiac output, and increased cardiac output responsible to increase the blood pressure. Hypertension, there are two major types: essential hypertension, or that is also called primary hypertension, and secondary hypertension. More than 90 to 95% patients with persistent arterial hypertension, but we don't know the etiology clearly. Genesis of hypertension unknown. Predisposing factors that we suspect, okay, maybe due to obesity, stress, salt intake, right, and smoking, and non-suspective like positive family history, insulin resistance, age, sex, defect of local vasomotoric regulation. Secondary is basically secondary hypertension is secondary to some distinct disease like renal disease or renovascular disease, for example, arterial stenosis, hormonal defects like Cushing syndrome, pheochromocytoma, mechanical defects, for example, coarctation of aorta, hypertension in pregnancy, drug-induced hypertension like sympathogenic drugs, glucocorticoids, right? This is very important to know because when there is a change in the blood pressure, this is important. Initially, body that tries to control this alteration or change in the blood pressure. There are major mechanisms. One of the mechanism is the baroreceptor. They are responsible for rapid adjustment in the blood pressure. And second one is kidney. Plays a key role in long-term control of blood pressure and in the pathogenesis of hypertension. Excretion of salt and water controls intravascular volume, which influences the force of contraction of the heart by starting mechanism. Secretion of renin in one third of patients increases production of angiotensin 2, and when secretion of increases production of renin, when there is low blood pressure, right? So what is the compensatory mechanism? What it will do, it will increases the release of renin, and renin is responsible to convert angiotensinogen into angiotensin 1. Then ultimately angiotensin 1 is converted angiotensin 2, And this angiotensin 2 is responsible to produce vasoconstriction and enhances the secretion of aldosterone. And aldosterone is responsible to stimulate reabsorption of sodium. When there is reabsorption of sodium, ultimately water also reabsorbed automatically. So this is when there is low blood pressure, renin-angiotensin aldosterone system is activated and try to increases the reabsorption of water and salt and increases the blood volume. Here, the secretion of renin increases production of angiotensin 2, causes direct constriction of resistant vessels and stimulation of aldosterone synthesis in the adrenal cortex, increases renal sodium absorption and intravascular volume. Renal disease like vascular, parenchymal, or obstructive is a cause of arterial hypertension. What are the drug strategies? Already we have discussed this is the multiple product of blood pressure, basically cardiac output and peripheral vascular risk. So our aim is to decrease the total peripheral resistance and decrease the cardiac output, decrease the body fluid volume, right? Because this is one of the reasons it increases blood body fluid volume. It will exert a pressure on the vessel that will lead to increased blood pressure. But this is important now. Body's compensatory mechanism. Already I have discussed with you when there is a drop in the blood pressure. So due to compensatory mechanism, due to decreased blood pressure, what it will do? Reflexly, reflex tachycardia. Because when there is drop in the blood pressure, so body thinks, okay, there's low blood pressure, so it will stimulate the sympathetic activity. So that is called reflex tachycardia due to increased sympathetic activity. And already I told you when sympathetic nervous system is activated, it's going to stimulate alpha 1 receptor, beta 1 receptor more specifically, and that will lead to increased blood pressure. Due to stimulation of alpha 1 receptor, and alpha 1 receptors predominantly present in the vessels. So it will, when there is a stimulation of alpha 1 receptor, due to stimulation of sympathetic activity, there is vasoconstriction. When there is vasoconstriction, it will increases the peripheral resistance. Increased peripheral resistance is responsible to increases the venous return. When increased venous return, increased amount of blood will come back into the heart for the next pumping, so increased cardiac output. And there is another mechanism due to increased cardiac activity, due to stimulation of beta 1 receptor, due to stimulation of sympathetic activity. Because predominantly on heart, beta 1 receptors are present. So stimulation of beta 1 receptors, it will increases cardiac contractility as well as will increases the heart rate. And there is another important point. Stimulation of beta 1 receptor, it will increases the renin activity. And already I told you when there is increased renin secretion, it will stimulate angiotensin aldosterone system, and this activation will lead to increased reabsorption of salt and water. So that is why you can see it may cause edema, increase body fluid volume, and that will again increases the blood pressure. The choice of antihypertensive drug will depend on the relevant indication, right? Or contraindications for the individual patients. So these are the major drugs. Diuretics, drug influencing sympathetic nerves, vasodilators, angiotensin converting enzyme inhibitors or receptor blockers. So these are the major groups of drugs, and today we are going to two main groups. Diuretics, the drug of first choice for treating patient with mild to moderate hypertension. and often combined with another drug in treatment of more severe hypertension. An example of thiazide diuretic, hydrochlorothiazide. An important example is chlorthalidone, but the most important example is hydrochlorothiazide, that is the prototype drug of this drug, where this diuretic acts on which segment of the nephron. Thiazide diuretics, because in the treatment of hypertension, we use two drugs because there are three important groups: thiazide diuretics, loop diuretics, and potassium sparing. Okay, so thiazide diuretics on which segment of the nephron it acts on the convoluted tube, right? So preferable to loop diuretics for the treatment of uncomplicated hypertension, right? Mild to moderate hypertension given by mouth as a single morning dose. Begin to act within 1 to 2 hours and work for 12 to 24 hours. Treatment should be started using a low dose. This is already we have discussed. The site of action is the distal convoluted tubule, and it blocks the sodium chloride to transport segment. So what will happen? There is no reabsorption of sodium and chloride. It will accumulate it in the lumen, and it will catches water from inside to outside, and this is how we can get rid of body fluid. Mechanism of action: lower blood pressure by reduction of blood volume. This is the main mechanism, and how that also we have discussed. And by direct vascular effect, inhibition of sodium chloride transport in the early segment of the distal convoluted tubule, arterioresis, decrease in preload and cardiac output, and uh, renal. This is the renal effect. Slow decrease or total peripheral resistance raised initially during chronic treatment, suggesting an action on resistance vessels. That is the extrarenal effect. Adverse effects very important from the clinical point of view, because when increased excretion of sodium, so it will lead to hyponatremia, and it also enhances the excretion of potassium. So when there is excessive amount of potassium is going to be excreted out, so it will cause hypokalemic state, hypomagnesemia, hyperuricemia. Most diuretics reduce uric acid clearance, so it may cause hyperuricemic state. So that means if a patient having a history of gout, they have to be very, very careful to start the therapy with this drug. Hyperglycemia, hypercalcemia. So from the exam point of view, 2 points are very important. Number one, this is one of the group that can cause hypokalemia, and second important point will cause hypercalcemia. That means, what does it mean, hypercalcemia? That means it enhances the reabsorption of calcium. It prevents the excretion of calcium. Where so when it will prevent the excretion of calcium, what will happen? Increase reabsorption of calcium, so ultimately it will increases the serum level of calcium, so hypercalcemia. One important point: azide diuretic or loop diuretic, both are responsible to cause hypokalemia, right? But one of the important difference between thiazide diuretic and loop diuretic, thiazide diuretic, it prevents excretion of calcium, and loop diuretic, it promotes excretion of calcium. Clear? So you must remember this important difference. Thiazide reduced urinary calcium and currents precipitate clinically significant hypercalcemia in hypertensive patients with hyperparathyroidism. So, what is the clinical correlation from the exam point of view? Suppose there is a female, old age female, having a history of osteoporosis, and that female requires a diuretic. So this is the question that is commonly asked in USMLE exam. So which one of the following diuretic you will opt in this lady having a history of osteoporosis? So definitely you will select thiazide diuretic because it prevents the excretion of calcium. So this is a very important point related to this thiazide diuretic. Loop diuretic, important, very important example is furosemide. Other examples are torsemide, ethacronic acid, but clinically we are most commonly we are using furosemide, useful in hypertensive patient with moderate to severe renal impairment or in patient with hypertensive heart failure. Relatively short acting, diuresis occurs over the 4 hours following a dose used in hypertension if response to thiazides is inadequate. Mechanism of action, they inhibit the co-transport of sodium potassium chloride, increases the calcium and magnesium excretion. Here you can see increases calcium and magnesium excretion, but the key difference is it enhances the excretion of calcium, whereas thiazide diuretic prevent the excretion of calcium. They have useful pulmonary vasodilating effects, but the mechanism of action is not clear. So the site of action or on which segment of the nephron acts on the thick ascending limb of the loop of Henle. Loop of Henle. That is why it is labeled as loop diuretic. So this you must know. The site of action. On which segment it acts? Thick ascending. Thick ascending because ascending limb consists of two portions, thin or thick segment. So it acts on the thick ascending limb of the loop of Henle and it prevents the sodium potassium chloride flow transfer. Now the toxicity, hypokalemic metabolic alkalosis due to increased excretion of potassium, autotoxicity. This is important side effect, dose dependent on fortunately it is reversible when we stop giving therapy, it can be reversible autotoxicity. Because of this point, any other drug that can also responsible to produce autotoxicity, so we'll have to be very careful to start the therapy with these two different groups of drugs that can produce autotoxicity. Suppose patient is taking loop diuretics and also it starts taking which antibiotic group, aminoglycoside, right? Aminoglycoside that will be also responsible to cause autotoxicity. Decrease of magnesium plasma concentration, hypomagnesemia, just like the thiazide diuretic, hyperuricemia, just like thiazide diuretic. It may cause sulfonamide allergy, risk of dehydration. Why? Risk of dehydration. Why? Because it's a powerful. This loop diuretic is supposed to be the powerful diuretic because it enhances the excretion of increased amount of body fluid volume. So it can be this volume can be decreased up to more than 4 liter in urine in 24 hours. And another important point already we have discussed, that is the key difference. It promotes the excretion of calcium, right? So again, I am going to correlate this point. If a patient having a history of osteoporosis, we are not going to promote to give if there is a need to give the diuretic on long-term basis treatment, right? Because if there is an emergency, we are required the rapid effect or powerful effect. Definitely, we are going to use the loop diuretics. But if long-term treatment is required, in a patient having a history of osteoporosis, we will prefer to keep the thiazide. Now, the second important group, drug influencing sympathetic nerves, and few points already I have discussed with you. What is that? Due to stimulation of sympathetic nervous system, what will happen? Stimulation of adrenergic receptors, alpha receptors and beta receptors, and there is another group of receptors that is called the dopaminergic receptors, right? So, stimulation of Alpha receptor, more specifically alpha 1. Now, already I told you on the vessels, predominantly we have alpha receptors or alpha 1 receptor. So, you know, when there is stimulation of alpha 1 receptor, it will promote vasoconstriction. And vasoconstriction, due to vasoconstriction, increase peripheral resistance. Due to this increased peripheral resistance, venous return will increase, and due to increased venous return, ultimately increased cardiac output. So, if we use alpha blockers or alpha adrenal receptor antagonists, so opposite effect will, it will block the receptor, so it will produce vasodilatation. And due to vasodilatation, relaxation of the smooth muscle, that will reduce the vascular resistance, decrease venous return. When decrease venous return, decrease cardiac output, decrease blood pressure. Clear? This is important, right? So that is why we have different drugs like competitive, non-competitive. Competitive, we have two different groups: short-term action or long-acting, right? Like in the short-acting drugs, non-selective. Non-selective means because selectively we are required to block the alpha 1 receptor, right? But the drug, if it's going to block alpha 1 or alpha 2, so that is the non-selective, like phentolamine and short-acting drug and alpha 1 selective drug, prazosin. This is very important, and this is one of the drugs that is being used in our clinical setting. Prazosin, alpha 1 selective antagonist, short-acting. These are the points that you mentioned. Long-acting, and again, alpha 1 selective, doxazosine, and terazosin. So these three examples, prazosin, doxazosine, terazosin, these are the alpha blockers that we are using clinically. Non-competitive with long-term action. What do you mean by competitive and non-competitive? Competitive means the action of this drug can be reversed by giving agonists, right? And non-competitive means the binding of drug is permanent with its relevant response. Even if we increase the dose of agonist, it cannot displaces that antagonist from its binding drug. That is why it is called non-competitive. The non-competitive is long-term action, non-selective. That is phenoxybenzamine. And this phenoxybenzamine is not being used usually to treat hypertension, except only one condition. This is important. This is one condition. That is called tumor of the adrenal gland. That is called the pheochromocytoma, right? In that condition, we specifically using phenoxybenzamine. Okay, this is very important. We are going to focus the main side effect. Very interesting. Postural change in the blood pressure. I think most of you are well aware of this term because suppose I'm in a sitting position. For example, I'm in a lying position and I change my posture from the lying position to suddenly in the erect posture, standing position. So what will happen? Ideally, what's going to happen? The blood will move towards downwards due to gravity. It should be dropped down, but it's not going to occur. Why? Why? Which mechanism prevent this uh, fall in the blood pressure? Right? Because when from a lying position I change my posture into standing position, so blood will have to move from head to toe due to gravity. But it doesn't happen. Why? Because when there is a change in the posture from lying position to standing position, alpha 1 receptors are stimulated, and due to vasoconstriction, it will prevent the sudden drop in the blood pressure, sudden fall in the blood pressure. Why? So this is important point. Why it is important? Because if a patient is taking alpha 1 blocker, what will happen? When there is a change in the posture, it will induce orthostatic hypotension or postural hypotension. Why? Because normally when there is a change in the posture, alpha 1 receptors are stimulated and it prevents the downward movement of the blood. So it prevents the drop in the blood pressure. It prevents the postural hypotension. But if a patient is on alpha 1 blocker, right? So this mechanism is blocked. So when there is a change in the posture, now there is no vasoconstriction. So blood will move from upward to downward and it will induce a mechanism that is called the postural hypotension. Clear? I think it is now clear. So the main adverse effects are drowsiness, weakness, but the most important is the orthostatic hypotension. I think now it's clear. So there is another term that we use as far as the adverse effect of alpha 1 blockers are concerned. That is, this is the group that may cause first dose syncope. First dose, what does it mean syncope? Because when there is a sudden drop in the blood pressure and the blood will move from head to toe, so what will happen? For a fraction of a second, the blood supply of the brain is compromised, right? So syncope is done. Clear? So how we can prevent this first dose syncope? If we are going to advise our patient, there are two mechanisms. Number one, we start the therapy with low dose, and second important, we start the therapy at bedtime. Clear? Okay. And for the non-selective agents, reflex tachycardia in patients with coronary disease, angina may be precipitated by the tachycardias. That's required in selective alpha 1 blocker. Why? Because simple mechanism, compensatory mechanism. When there is relaxation of the vessels, cooling of the blood, decrease venous rhythm, decrease cardiac output. So it will induce reflex activity. So it will increase sympathetic activity. So it will cause reflex tachycardia. More specifically, why it is related to uh, non-selective? Because alpha 1 receptor predominantly on vessel. Okay, that we have already discussed. Alpha 2 receptor, alpha 2 are present in the presynaptic terminal, and basically it inhibits the activity reflexively. So stimulation of alpha 2 receptor, it will prevent the further release of norepinephrine from the nerve terminals. This is how it can control the activity of noradrenaline. But if a patient is going to take non-selective alpha blocker, okay, it will not only block alpha 1, but it will also block alpha 2 receptor. So now what will happen? There is no control reflex or feedback control or inhibition of norepinephrine release, because stimulation of alpha 2 receptor is responsible to inhibit the further release of noradrenaline or norepinephrine. When we block this receptor activity, there is no feedback control, persistent release of noradrenaline, and it will stimulate the sympathetic activity. Clear? Okay, second very important drug, that is the beta receptor antagonist, and already I told you predominantly on heart beta 1 receptors are present, and another activity of beta 1 receptor stimulation is the increased release of renin from the kidneys. So when stimulation of beta 1 receptor, it stimulates cardiac activity, increase contractility, increase heart rate, right? When we block this receptor, what will happen? Decrease contractility, decrease heart rate, decrease cardiac output, decrease blood pressure. And it also reduces the renin secretion. So what is the importance of renin secretion towards blood pressure? Already I told you, when renin is released, it stimulates production of angiotensin 2, and angiotensin 2 is responsible to reduce vasoconstriction and increase secretion of aldosterone, and aldosterone is going to promote reabsorption of sodium and water, right? Okay, again, there are different beta-adrenergic receptor antagonists. So predominantly on heart beta 1 receptor. That means we are specifically required beta 1 receptor blocker to block the cardiac activity, right? Cardio-selective beta blocker. And beta 1 blockers, we have atenolol, metoprolol. So these are the two important examples of drugs that we are using clinically, right? And beta 1 blockers with ISA, what do you mean by this ISA? Intrinsic sympathetomimetic activity or partial agonist activity. These drugs not only block the receptor but slightly stimulate the receptor as well. So there is no absolute blocking activity here, like acetylol, and there are some drugs, non-selective drugs. That is very important example, levodopa and carvedilol. Again, these are the two very important drugs. These drugs not only block beta 1 receptor but also block alpha 1 receptors, specifically labetalol. This is the drug that can be used in emergency to treat severe hypertension. This is very important. And you know, this carvedilol, this is another very important example of drug that we are using in the heart failure patient, chronic heart failure patient to control the blood pressure, this carvedilol. Cardio non-selective, clear point, not only block beta 1 but also block beta 2, like metoprolol, propranolol, nadolol. Propranolol is one of the key examples. So, what is the difference? Why we are required the cardio-selective beta blocker? What's going to happen if we are using non-selective, like the drug that can block not only beta 1 but also beta 2, like propranolol? The important point is, beta 2 receptors, stimulation of beta 2 receptor responsible to produce relaxation of the bronchial smooth muscle. So if a patient having a history of asthma and you are using non-selective beta blocker, it will induce bronchoconstriction due to beta 2 receptor blocking activity. So it will exaggerate the attack of asthma in that patient. So already I told you this term of ISA, intrinsic sympathetomimetic activity or partial agonist activity, may be an advantage in treating patient with asthma because these drugs will cause bronchodilation. They have moderate or lower effect on lipid metabolism, cause laser vasospasm, and negative inotropic effects. Adverse effects, cardiovascular effects, which are extension of beta blockade include, okay, when we are blocking beta receptors, normally beta 1 receptor stimulation will lead to increased heart rate, tachycardia, so opposite effect. When we are going to block this receptor, it may cause bradycardia. Atrioventricular blockade, congestive heart failure, asthmatic attacks in patients with airway disease. So premonitory symptoms of hypoglycemia. This is very important point, because the stimulation of beta 2 receptor, it induces the process of glycogenolysis by promoting increasing the release of glucagon, right? So normally beta 2 receptor stimulation will lead to hyperglycemia. So if a patient having a diabetic patient, suppose, and that patient is already taking anti-diabetic drug, and if we use beta blocker, so I am repeating the normal function. Stimulation of beta 2 receptor induces process of glycogenolysis during the release of glucagon, so it will produce hyperglycemia. So when we block this receptor, it will produce opposite effect, hypoglycemia. So it may create a problem in diabetic patient because diabetic patient already taking anti-diabetic drug which controls the sugar level, right? So if we use beta blocker, it will further reduces the sugar level. So it may produce hypoglycemic state, right? Centrally acting. This is another very important group, alpha 2 agonist action. And two key examples, methyl dopa and clonidine. Limited use in the treatment of hypertension. We are not using commonly, but methyl dopa can be used in hypertension during pregnancy. Very important point. That means pre-existing chronic hypertension in that pregnant lady. Hypertension not developed after the pregnancy. Because if hypertension develops after the pregnancy, then we can label as the preeclampsia. Right? So methyl dopa, hypertension during pregnancy, methyl dopa causes symptoms of drowsiness and fatigue that are intolerable to many adults. Patient in long-term use, they are seldom used to treat essential hypertension. Now, this is important point. Clonidine is potent but poorly tolerated because if we are using clonidine to control blood pressure, it may cause rebound hypertension if we suddenly withdraw the treatment. Yeah? Clonidine can be used in opioid withdrawal. This is another important clinical use of this clonidine. And clonidine and methyl dopa, they both responsible to cause sedation, right? This is an important point. And this is the last slide. I think the most favorite slide of every student. So this is all about. So I have finished this lecture on time. So inshallah, the remaining drug groups that we will discuss tomorrow. Thank you.
ठीक है सर, एंड कर दूं?
जी जी है, ठीक है ना? कल तो मैं कल से कल तो 11:20 पर है ना लेक्चर मेरा।
स्केड्यूल देखा नहीं मैंने।
चले ठीक है, मैं देखूँ। चले कोई मतलब कोई।
थैंक यू
ओके, थैंक यू सो मच। अल्लाह हाफिज़।